We are now at week 7 and 8, human birth defects, genetics and environment, and assessing fetal status, part 1. The learning objectives for week 7 and 8 are to discuss the roles of the signaling pathways, the transcription factors, and epigenetics in human development, to describe the birth defects caused by chromosomal and genetic factors, describe birth defects caused by environmental factors, list the known human teratogens and explain relevant mechanisms and timing of maldevelopment, describe methods for estimating fetal age, describe the indications for and risks and benefits of prenatal ultrasound diagnostic amniocentesis and CVS, to describe the procedures of amniocentesis and CVS, the subsequent um, cell cultures and laboratory analyses, to describe the challenges of cell culture interpretation in cases of true mosaicism and confined placenta mosaicism. In looking at fetal age, ultrasound measurements of the crown rump length, the CRL, of the fetus are taken to determine its size and probable age in order to predict the expected date of delivery. Fetal head measurements and femur length are also used to evaluate age. Gestational age is usually time from the onset of the last normal menstrual period, which is the LNMP. Please look at this ultrasound image showing you how the crown to rump length of a fetus is measured. In looking at how to measure fetuses, CRL is the method of choice until the end of the first trimester, since there's little variability in fetal size during this time period. During the second and the third trimesters, the most common measurements are the biparietal diameter, which is the diameter of the head between the two parietal eminences, the head circumference, the abdominal circumference, the femur length, the foot length, and also weight. Now, weight is often quite useful for estimating age, but there can be a discrepancy between the age and the weight, particularly when the mother has a metabolic disease such as diabetes during pregnancy. When this happens, the weight often exceeds the values considered normal for the corresponding CRL. So fetal dimensions are obtained from ultrasound measurements, closely approximating the CRL measurements obtained from spontaneously aborted fetuses. The determination of the size of the fetus is also important because if you take a look, say, at the head circumference, it's helpful for the obstetrician for management of the patient. Viability refers to the ability of fetuses to survive the extrauterine environment. Most babies weighing under 500 grams do not survive. Many full-term low birth weight infants result from intrauterine growth restriction, or IUGR. Babies born under 500 grams may survive and are referred to as immature infants or extremely low birth weight infants. Babies born weighing between 750 and 1500 grams usually do survive, but have many complications that can occur, and these are referred to as preterm infants. Approximately 500,000 preterm infants are born in the United States each year, and many of them suffer from complications or early mortality. Prematurity is one of the most common causes of morbidity and perinatal death. Not all low birth weight babies are premature. Approximately one-third of those born with a birth weight of 2,500 grams or less are actually small for gestational age. Maybe they're underweight for placental insufficiency. The placentas are, in this case, would be often are small or poorly attached and or have undergone degenerative changes that progressively reduce the amount of oxygen being supplied to the baby and nourishment to the fetus. It's important to distinguish between full-term neonates who have a low birth weight because of intrauterine growth restriction and those preterm neonates who are underweight because of a shortened gestation, such as being premature by their due date. IUGR may be caused by preeclampsia, which is due to hypertension, smoking, or some illicit drugs, multiple gestations, for example, with triplets. infectious disease, cardiovascular defects, inadequate maternal nutrition, and maternal and fetal hormones. Teratogens and genetic factors also have been known to cause IUGR. Infants with IUGR show a characteristic lack of subcutaneous fat and their skin is wrinkled, suggesting that white fat has actually been lost. The expected delivery date for a baby is 266 days or 38 weeks after fertilization, or 280 days or 40 weeks after the last menstrual period. Approximately 12% of fetuses are born 1 to 2 weeks after the expected time of birth. Post-maturity syndrome is where the pregnancy goes on for 3 or several weeks beyond the expected date of delivery, and this occurs in about 5 to 6% of women. Some infants develop post-maturity syndrome, which may be associated with fetal dysmaturity, and this includes absence of subcutaneous fat, wrinkling of the skin, meconium, greenish-colored feces, staining of the skin, and excessive weight. Some of the factors influencing fetal growth are factors that operate throughout the pregnancy, and these can be maternal, fetal, or environmental. And when this occurs, this tends to produce infants with IUGR or small for gestational age, including the following: maternal vascular disease, intrauterine infection, cigarette smoking, and consumption of alcohol. Factors that only operate during the last trimester, such as maternal malnutrition, usually produce underweight infants with normal length and head size. The terms IUGR and SGA are related, but they are not synonymous. So intrauterine growth restriction versus small for gestational age, if we look at the two of them and compare them, the IUGR is a process that causes a reduction in the expected pattern of fetal growth as well as in fetal growth potential. The SGA infants have a birth weight that is lower than a predetermined cutoff value for a particular gestational age. And low birth weight has been shown to be a risk factor for many adult conditions, including hypertension, diabetes, and cardiovascular disease. High birth weight due to maternal gestational diabetes is associated with a baby developing obesity later and diabetes in babies. So let's just look at a few environmental factors that have a bearing on the size of the fetus. Smoking is a well-established cause of IUGR. The growth rate for fetuses of mothers who smoke cigarettes is less than normal during the last 6 to 8 weeks of pregnancy. On the average, the birth weight of infants whose mothers smoke heavily during pregnancy is 200 grams less than normal, and the rate of perinatal morbidity is increased when adequate medical care is unavailable. The effect of maternal smoking is greater on fetuses whose mothers also receive inadequate nutrition. And cigarette smoking has been implicated as a major cause of cleft lip and cleft palate, which we discussed before. Taking a look at multiple pregnancies, if you have multiple births, it usually the babies weigh less than infants that are born resulting from having a single pregnancy. It is evident that the total metabolic requirements of 2 or more fetuses exceed the nutritional supply available from the placenta during the 3rd trimester. Looking at alcohol and illicit drugs, we see that infants that are born to mothers that drink alcohol often exhibit IUGR as part of the fetal alcohol syndrome. Similarly, the use of marijuana and other illicit drugs such as cocaine and heroin can cause IUGR and other obstetric complications. Maternal placental circulation may be reduced by conditions that decrease the uterine blood flow, and these include having small chorionic vessels, severe maternal hypotension, and renal disease. The chronic reduction of uterine blood flow can cause fetal starvation, resulting in intrauterine growth restriction. Placental dysfunction can also cause IUFR. The net effect of these placental abnormalities is a reduction of the total area for exchange of nutrients between the fetal and maternal bloodstreams, and it's quite difficult to separate the effect of these placental changes from the effect of the reduced maternal blood flow to the placenta. In some cases of chronic maternal disease, the maternal vascular changes in the uterus are primary and the placental defects are secondary. So structural and numeric chromosomal aberrations have been shown to be associated with cases of retarded fetal growth. For example, Down syndrome and Edwards syndrome. So what I'd like you to do now is to go back and look at the videos that are associated with this first part. Please look at the one on fetal alcohol syndrome for a review, as well as looking at gestational age and looking at how we assess the baby during the beginning of the pregnancy. And then we will go on to part 2.